All right, my name is Dr. Taylor Hilton, and I'm going to present a case for unexpected cardiac arrest during an AV fistula. Our case was a 50-year-old morbidly obese woman. She unfortunately had end-stage renal disease in which she was getting an AV fistula superficialized and placement of the graft. She had hypertension, hyperlipidemia, and venous insufficiency, as do most of our end-stage renal patients. Luckily for her, she had a normal echo with normal biventricular function. She had a normal EF. She did have grade 1 diastolic dysfunction, but there was no fluid in the pericardium and all her valves were normal. Her EKG prior showed a bivesicular block, which is a left anterior vesicular block with a combination right bundle branch block, which was abnormal, but that was the significant salient history for the case. Our anesthetic plan for her was a supraclavicular nerve block with a PEX2 block. We did not opt for sedation because the last time she had a procedure done under sedation, she had to be emergently intubated for primary respiratory arrest. And so we wanted to avoid any primary respiratory events during the case, so we decided to intubate her from the start and then just proceed with the general anesthetic with combination block. And the reason we did the block is because there's some evidence to support that a supraclavicular nerve block or brachial plexus block can improve graft function for the patients who are getting fistula placements. The course of events for the first 2 hours was pretty unremarkable. You can see at the image at the bottom, we had an uneventful intubation with a D blade. We also had stable hemodynamics to start. No major swift, no major swings, no hypotension, and she didn't have any vasoactive requirements with phenylephrine or norepinephrine to keep mean arterial pressures in a normal range. Our first sign of trouble was that we had an acute drop from 32 to 35. You can see in the red box, you have an end tidal drop from 39 to 8, and this was associated with VFib arrest, and so I called Dr. Kravets to come into the room, and he confirmed that we did have true end tidal CO true drop with VFib arrest, and so we notified the surgeon and immediately started CPR. You can see here stable hemodynamics on the right, and then all of a sudden unreliable pleth wave and cardiac arrest ensued. Immediately what we did is we notified the surgeon, started CPR, called for qualified help, and Dr. Kravets initiated tasks being delegated through ACLS. Our differential at the time was wide as we had an acute, unexpected cardiovascular collapse, so pulmonary embolism was high on our differential, myocardial infarction and or ischemia, and we had evidence of a malignant arrhythmia occurring. Dr. Kravets at the time called for a CV surgeon in the room, and what he was thinking was peripheral ECMO candidacy, given that we had unexpected cardiac arrest. If we were unable to find a reason for the arrest, it would be reasonable to at least establish candidacy for ECMO, given we weren't quite sure what just happened. We called for a rescue TEE, and he was going to assess both the right ventricle and the left ventricle to see if we had any RV dysfunction and or LV dysfunction, pericardial effusion, or any valvular abnormalities that would be unexpected. I turned our flow rates to FiO2 of 100%, turned off our volatile gas, and I immediately gave 1 milligram IV epinephrine, and we delegated to have the pads placed. Within one round, we were able to get return of spontaneous circulation. Senior resident Dr. Matson came in to place an arterial line very swiftly, and we started to transcutaneously pace the patient. We were able to get mechanical capture, but the patient was being almost paced off the table with the amount of voltage that was needed. And so we knew that we needed a transvenous pacer. So Dr. Kravets had called the ICU attending to determine where the transvenous pacer was. According to ACLS algorithms, we then started a high dose of epinephrine and dopamine to pharmacologically temporize to see if we could get a pharmacologic benefit from the high V nodal AV block. We tried a milligram of atropine, knowing that this may be ineffective with some glycopyrrolate. And then Dr. Kravets had also called for isoproterenol in the event that epinephrine and dopamine were ineffective. ECMO wires were placed both in the left femoral artery by the cardiovascular surgeon, and Dr. Kravets was talking to the surgeon about, in the event we were unable to obtain swiftly a transvenous pacer, if placement on peripheral VA ECMO would be a better option, or would emergent unexpected sternotomy for epicardial pacing be the best option for her. After discussing with the cardiovascular surgeon, he wanted to wait for a transvenous pacer as we were starting to get pharmacological improvement from both epinephrine and dopamine, rather than to put the patient on peripheral VA ECMO, and we wouldn't need an emergent sternotomy for epicardial pacing. We also tried esophageal pacing before the TEE arrived, but once the TEE arrived, Dr. Kravets thought that it would be best to have real-time TEE guidance with a dynamic unexpected cardiac arrest rather than the esophageal pacer. The patient unfortunately developed a second arrest. This time a smaller dose of epinephrine was given, 100 mics IV, and we were also able to achieve ROSC in one round. At this time, we both had a transesophageal echo arrive in addition to a transvenous pacer arrive by one of the electrophysiologists, Dr. Orlovsky, and his fellow. The patient already had a temporary hemodialysis catheter, and so we accessed that catheter for our high-dose inotropic support, and then we decided Dr. Kravets wanted to delay central venous placement with a MAC and a Swan, which would be a 9 French, and he wanted to wait for the specific 6 French setup, as it's a different sheath that is usually involved in the transvenous pacer than is a traditional MAC line. So the two types of transvenous pacers that are traditionally available is the one on the left has a filamentous rod with a balloon. This is more sturdy as you float it, similar to a Swan. The one that they had was a very flimsy catheter that's very, very difficult to float, and it really takes guidance of both fluoroscopy and or transesophageal echo to float this particular balloon into the right ventricle. This option on the left was not available, and so we had to utilize the catheter-based transvenous pacer, which took multiple attempts. We were unable to guide this with transesophageal echo swiftly, and so we called for a C-arm to float this under partial fluoroscopy. Our labs, after we were arrested, showed a primary respiratory acidosis, and then we also adjusted our vent, but the patient did have acute hypoxic respiratory failure. And given they had, ESRD, we were wondering if this was a hyperkalemic arrest, when even post-ROSC, we had a normal potassium. Chest x-ray is shown here. You can see the lead, the transvenous pacer is finally in the RV. In addition, we have the existing hemodialysis catheter in place here. We have a transesophageal echo. We have some pulmonary edema on the right lung, and we ruled out pneumothorax, as you can see, interstitial markings going all the way to the distal end of the lung. Given that they performed a left-sided supraclavicular nerve block with a PEX2, we were able to rule out pneumothorax as the cause of this arrest. The immediate postoperative course, the patient was stabilized, transvenously paced at VVI at 80, and stabilized on epinephrine and dopamine. They were hemodynamically stable, although in a guarded critical condition. The patient was alive and moving her extremities and following commands in the ICU. And so that was a win for our team in the immediate setting. Her postoperative cath the next day showed that she had some disease, and this is a picture of her actual cath. You can see she had proximal RCA lesion that was 80% stenosed. She also had stenosis of the distal circumflex, and these were stented successfully with percutaneous coronary intervention. So how does this potentially relate to how she arrested? So there's a couple hypotheses that Dr. Kravets and I were talking about. And what it was if you have a right bundle branch block, the right fascicle will not be able to conduct to give the myocardium, its electrical impulse to contract. And so if the left anterior fascicular block is blocked, you only have this left posterior fascicle that is basically functioning normally. So this SA to AV and this fascicle here is, if it gets ischemic, would be prone to third degree heart block because only this fascicle needs to be compromised in order to have a problem. Well, if we look back at her cath, the fascicle is, the RCA will perfuse the SA and AV node, and potentially a little bit of the posterior fascicle could be supplied by branches of the left circumflex, both of which were diseased. And so she went for an EP study about a week later. She had a negative EP study for sustained ventricular tachycardia, according to Dr. Orlovsky, per Dr. Kravets' conversation. She did, however, have an HV interval prolonged conduction, which is the conduction time between the proximal His bundle to the ventricular myocardium. So the His bundle would be right here to the myocardium. That was delayed. But what it essentially means is that an ICD is not recommended, even though she had a VFib arrest, because they cannot conclude, because they didn't have the strips, that it was true VFib arrest. However, he did recommend a leadless pacemaker was preferred based on her lack of options for venous access, being an ESRD patient, and the risk for infection would be high. So ICD was not warranted, but a leadless pacemaker would be warranted at a later time. She was then extubated a couple days later, still neuro intact. She unfortunately developed acute hypoxic failure, again had to be reintubated, but a few days later recovered and was able to be extubated, and she's getting ready to be discharged from the hospital. So what exactly happened? Dr. Kravets and I have a few hypotheses. Myocardial ischemia will be likely, given the effects of the bifascicular block with coronary disease, puts your conduction system at risk. It's very vulnerable. Also, if the patient did become ischemic and did develop a form of bradycardia, as we become more bradycardic, our QT widens, and the more bradycardic you get, the longer your QT interval becomes, the more likely you're to develop an R-on-T phenomenon and potentially develop a VFib arrest that would be sudden. So Dr. Kravets and I agree that myocardial ischemia, given evidence of coronary disease, the anatomical location of that disease, in addition to what she had on EKG prior, it's probably reasonable to say she had an ischemic event. What's unlikely is that she had a pulmonary embolism. She had severe P to F ratio, but the RV was intact and the P to F ratio improved over time. She never had a formal CTA study done of her chest, but since it improved and she was able to be extubated and the RV was normal, it's unlikely. What we ruled out in the OR was that she didn't have a pneumothorax. We ruled this out with lung sliding. She didn't have hyperkalemia. She didn't have RV dysfunction. And she didn't have any hyperkalemia. And so all of these events, point to the fact that this was likely induced from myocardial ischemia. So I'm opening the floor to any questions.